Hello, everybody. My name is Joe Scott. I'm the president and CEO of Jersey City Medical Center and Liberty Health, and welcome to the Medical Center Show. February is Heart Month, and so today we have with us Dr. Tyrone Krause, our premier chief of cardiovascular surgery. And Dr. Krause, tell us a little about yourself and when you came to the medical center and why you chose to come to Jersey City.
Well, thank you, Joe. My training started 17 years, well, took 17 years. I went to NYU undergrad, and then I went to medical school at New York Medical College. So
from college till you were done your cardiovascular residency, cardiovascular surgery residency, it took 17 years? Wow, I never realized that. Wow.
Well, like I said, the undergraduate in medical school, and then there was 9 years of actual surgery training.
Wow.
Because you have to go through a general surgery training first. And then I finished
So you completed a general surgery residency, and then you did a cardiovascular surgery residency?
That's correct. And that's the requirement to get into or be eligible to get a fellowship for cardiac surgery, cardiothoracic
and
surgery.
Where did you do your training?
And I did my cardiothoracic training at New York Hospital in Cornell.
So again, we have all these great New York doctors who got trained in New York and now are at Jersey City Medical Center. There's really no reason to go into the city for their health care, right?
Absolutely none.
We have a beautiful brand new facility.
It's a new facility. It's state-of-the-art cardiac surgery. We have a 24/7 in-house cardiac surgery team.
Right.
All designated cardiac anesthesiologists. And we'll talk about this a little more later.
Sure.
But it's just a full complement of whatever it takes to the full gamut of cardiac surgery, from coronary bypass surgery to valve surgery to heart failure surgery to arrhythmia surgery and aneurysm surgery. And again, we'll probably talk about this a little more in detail, but that's the general idea that we put forth at the medical center.
So before we were talking with our chief of cardiology, and she talked about some of the things associated with heart disease and congestive heart failure and how we treat that. Tell us a little bit about why does somebody go for open heart surgery? Can't the cardiologist just take care of them? And what makes them come to you? And you know, what's that all about? How come?
Well, you know, you're right. There are a lot less patients going to surgery compared to, say, 10 years ago. Coronary bypass, not as many patients go to surgery, and for the reason that she probably gave you, she must have gone over a lot of the cholesterol medications, which more and more we believe are lowering the plaques in the arteries that cause the blockages. And there are other medications. And then there are also procedures. The interventional cardiologist that she mentioned is a person who, in the cath lab, without going to surgery, puts a wire down the coronary artery and is able to open up this artery. So
they don't need surgery.
They won't need surgery. That's right.
So when do they come to you?
So they come to us when basically they can't do anything else. They've really run to the end of medicine and angioplasty, this balloon angioplasty. If they have a blockage in a certain area of the heart, for example, if this is a model of the heart, if the blockage is up in the middle of the main artery on the left side, it's called the left main artery. In this country, at least, the first-line treatment is surgery. It's too risky to do a balloon angioplasty. So there are certain blockages that just can't be done in the cath lab.
Okay, so explain that to me. So you say if they've got a blockage here, it's too risky to just put a stent in and just open it up.
That's correct.
What's the risk?
Okay, the risk for the left main artery supplies about 2/3 to 3/4 of the blood supply of your heart. And there is a risk of the stent not working. It may be anywhere from 1% to 5% that may disclose, regardless of what you do. It may either spontaneously, or a week or two later, or a month later, or 6 months later. So in a relatively short period of time, it could close. And the reasons for that are multiple, but in general, if the lesion or the blockage is complicated or complex, the risk may be higher for blocking. So if you just think about it, if you have 3/4 of your blood supply up here, and the stent closes, that stops the blood supply to 3/4 of your heart. And what happens when that happens is your heart just stops. So the mortality rate would be too high.
So those people, somebody could go home with one of those stents and then just have a sudden cardiac arrest, and that would be it for them.
And that would be it for them.
So when doctors see that kind of lesion, they call you and say, hey, you need to take care of this guy.
Yes, there are
or this
selected times when they may do an angioplasty to that,
right,
if they feel the patient is not a surgical candidate. They have cancer, for example, that's
right,
advanced, or multiple other medical problems, or say they're too old and frail to withstand surgery. Then they would get an angioplasty to that.
Right.
But most patients are robust enough to undergo general surgery to have. And just if I can mention a little bit about the actual surgery compared to, say, even 10 and 20 years ago. I got started 20 years ago. It was a much more invasive procedure.
Right.
Now, with the techniques advanced, the surgery is, the incisions are smaller. The incisions are smaller from your lower extremities. There are different techniques, not going on the heart-lung machine compared to on-pump,
right,
off-pump.
So some people, you actually work on the heart while it's still beating?
Yes.
Okay, so that's called
off-pump surgery.
Off-pump surgery. And how often do you do that?
Again, it's selective. At the medical center, probably about 30% of our patients we feel can have off-pump safely.
Okay.
And just think about it a bit. The heart-lung machine was really invented to operate on the heart because, as you know, the heart pumps blood.
Right.
You make a hole in the heart, the blood's going to splatter all over the place, and you're not going to be able to do the surgery.
Right.
So the heart-lung machine replaces the heart during that time you're doing the surgery.
I see.
And it really helped us back in the late 60s, 1960s, when coronary bypass, for example, got started, to do the actual surgery. Because it allows us to slow the heart rate down or stop it, and to do a suture bypass in a bloodless field.
Sure.
So when you think about off-pump bypass, the heart is beating. How are we actually suturing to the heart?
And so how do you do that?
And so what we do is we have stabilizers, and basically what they are is just little arms made out of padding, and we actually place them against the beating heart, and that little area, that we're going to do the bypass to, is rendered stationary.
Wow.
So that little area is not moving.
Right.
And we pull up loops in order to help minimize the blood flow during that procedure. It takes about 5 to 10 minutes to do a bypass.
I hear you're really great at it, too.
Well, I don't know. I mean, I survive, I guess. But it's like anything else. You wouldn't survive long if you weren't good.
And so when you talk about bypass surgery, you're actually bypassing the vessel. That's why they call it bypass. You're bypassing, like you're going around that vessel that's blocked.
Yeah.
And are you taking a vessel from somewhere else, or how's that?
What we do is I'm just a glorified plumber.
Oh, a plumber.
Basically,
that's a good way to think of it.
Yeah, it's a human plumber.
Right.
If you have a blockage in the coronary, we don't cut it out, because I get this question all the time from patients. Do you cut that out? What do you do with that blockage? Is it going to stay there? The blockage stays there. And basically, what we do, we get a new pipe. Right. And in medical terms, we get a vein from your leg.
Right.
We make a small incision like this, and we're able to. In the past, we had to open up your leg all the way down to your ankle.
Right.
Now we could do what is called endoscopic surgery, where we make a small incision, and we take the vein out. Or there's an artery underneath the breastbone. It's called the internal mammary artery.
Right.
And again, looking at the model, this is if you. Imagine that these are the coronaries. This is your heart.
Right.
And the arteries that we're bypassing on the surface of the heart, just like this.
Oh, okay.
This is about the size of the heart also.
Heart. Okay.
And imagine this being a vein that we just took out from your leg, and we suture it. Now, again, imagine there's a blockage, say, here in this coronary artery. So say the blockage is there. We'll suture this beyond it like that. So it's just like a bypass.
So it bypasses where the blockage is.
Just simply bypasses.
That's why they call it bypass surgery.
Yes.
Huh. That's very, very interesting. That's pretty amazing. Now, when you take this thing out of their leg, doesn't that become a problem? I mean, don't they have to worry about blood flow in their leg, or what's the deal?
Well, when I teach the students, I usually tell them that God put superficial veins in the leg, anticipating that someday there would be heart surgery.
Be a heart surgery.
So
that's funny.
So there are deep veins in your leg, and there are superficial veins, and the superficial, unless you have a problem with your lower extremities.
So you're like not taking like the femoral artery out of their leg. You're just taking a vein that's on the surface?
Yeah. It's on the surface, and it's virtually not needed.
Okay. Do they get like a scar, or do they, what's?
Like I said, 20 years ago, we used to open up from the groin all the way down to your ankle. Now we're able to take the whole vein out by making a small incision. Wow. And you hardly see this incision. Yeah. Well over 90% of our patients were able to do this endoscopic vein harvest, it's called.
Wow. Oh, that's great. Now, since you've come to the medical center, you've done an awful lot of surgery. How many surgeries will you do every year?
Well, we're trying to increase it. Before I retired, I always like to say, 10 years ago, I used to do 600 to 700 operations a year myself.
Wow. Wow.
When I first came to the medical center, we did a little over 100. We're doing, last year we doubled that. We did 215, and we're targeted probably to do closer to 300 this year. So we're really growing at the medical center.
That's right. And we talked a little bit about like the specialists that need to be there. You need you need a team, right, that really works not only on the patient in surgery, but after surgery. I mean, how's that all work?
Yeah. That to me is probably the most important part. Just the other day, I transferred a patient from an outlying hospital, and the family was asking me about that specifically.
Right.
They said, we checked you out, we went on the computer, and we saw you're a good guy, but what about the team?
Right.
Because we know a good portion of the surgery is related to the aftercare.
Absolutely.
We have designated anesthesiologists, the people who put you to sleep in the operating room, just designated for cardiac surgery.
And do they have special training?
They have special training, an extra year of anesthesia where they just do a fellowship in cardiac surgery.
Wow.
And then we also have physician's assistants that are designated just for cardiac surgery. And not only are they just for cardiac surgery, but they're in the hospital 24 hours a day.
Oh, I see.
We've had any question by a nurse or one of the other ancillary people. They are there at the bedside, taking care of problems in close contact with the surgeon.
So they're always in touch with you if anything happens, and they can get a hold of you right away.
Yes.
Yeah.
And then we also have probably the most important part. I can't forget the nurses.
Yes,
they're probably the most important part of the team.
Listen, if you forget the nurses, you're in big trouble, brother.
Yeah, I'm done.
You know,
that is true.
They're kind of that machine that kind of keeps everything flowing.
Absolutely.
So, and we have great critical care nurses, right? I mean,
excellent. It's expanded since I've gotten there, and we're growing. Actually, next month we have our own designated ICU just for cardiac surgery.
So we've grown so much, we have a cardiac surgery ICU. So we'll probably call this cardiovascular ICU, and that's a great thing.
Yes.
Yeah. We're here with Dr. Tyrone Krause, the Chief of Cardiovascular Surgery at Jersey City Medical Center, and we'll be right back after this break.
Jersey City Medical Center, Hudson County's #1 hospital, as ranked by U.S. News and World Report. Hudson County's only hospital to receive an A safety score rating. Jersey City Medical Center is Hudson County's only hospital to receive the prestigious Magnet Award for Nursing Excellence. Make the #1 hospital in Hudson County your first choice for quality health care. Jersey City Medical Center. Visit us on the web at libertyhealth.org. Seeing the ER doctor at the Jersey City Medical Center has never been easier. If you're sick, you just click. Go to libertyhealth.org, and here's how it works. Click Skip the Wait. Select your time and check in now. Enter your symptoms, your personal information. Click Proceed to Confirmation, and the doctor's waiting for you. The Jersey City Medical Center. Make Hudson County's #1 hospital your first choice. It takes more than a state-of-the-art medical facility to make a great hospital. It takes a team of dedicated medical professionals. That's the Jersey City Medical Center, Hudson County's #1 hospital. Medical teams consisting of New Jersey's top doctors, Magnet Award-winning nurses, and accomplished hospital associates, all committed to your good health. That's what you have at the Jersey City Medical Center. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center. On the web at libertyhealth.org.
Hi, Joe Scott, the president of Jersey City Medical Center, here with the Medical Center Show and with Dr. Krause, our chief of cardiovascular surgery. We were talking a little bit about cardiac surgery, and you explained bypass. There's other kinds of cardiac surgery that you do, right? Tell us a little bit about that.
Yes, at the Medical Center, we do basically all heart surgery except for transplant. And that consists in valve surgery, which is probably the second most common surgery we do besides bypass. Valve surgery, usually the aortic and mitral valve. And occasionally we'll operate on a tricuspid valve, but for the most part, that's the aortic valve surgery, for example. It could occur in a patient that's 40 years old up to 90 years old.
So why do they get that? Is it there's something wrong with their valve or something?
Yep.
And the valve is the thing that kind of opens and closes? Is that?
There are 4 valves to the heart.
Right.
Just to show again. The mitral valve this is the mitral valve. It separates the left atrium from the left ventricle. The aortic valve is up here. And those are the 2 main valves that have stress from, sometimes even from birth. A person, for example, may have mitral valve prolapse, maybe 2% of the population with that. And eventually, a small portion of those patients could develop surgery. The aortic valve, you could be 50 years old and have a blocked valve. It's called aortic stenosis. Very commonly, we operate on that. I just saw a patient today, 45 years old. She had a congenital problem with her aortic valve. So it's a pretty common.
When you say congenital, that means from birth?
From birth, she had, normally there are 3 leaflets to the valve. She was born with 2.
Oh,
again, about 2% of the patient population will have that.
And how old was she when she came to you?
Just the other day, she's 45 years old.
So did she not know that this was going on?
She knew it's one of those things where you've heard, and a lot of people will say, you know, my doctor when I was 5 years old said I had a murmur.
Right.
Almost always you outlive it and outgrow it. And in her case, that murmur was something that was physically wrong, and she just did not outgrow it, and it turned into a blocked valve.
Wow.
So. And again, some of the symptoms, which were I know briefly talked about in your cardiology segment, are going to be shortness of breath.
Right.
And sometimes you could have chest pain, like a heaviness on your chest.
Wow.
Sometimes you see swollen ankles. There's general symptoms of congestive heart failure.
Right.
The other type of surgery we do is aneurysm surgery. An aneurysm is a weakening in the wall of the artery. If this is the aorta,
right,
going all the way around, sometimes this gets to be a certain size.
It's kind of like a bubble there?
Just a bubble. It's just similar to a balloon. If a balloon blows up, it gets to a certain critical size, and it'll just spontaneously rupture. This artery, if it gets to be a certain size, now how do you have that? Or how do you get that?
Does it rupture, or do we find it? Like, didn't we just had a patient come into the emergency department probably a year ago. She was actually pregnant, and she was complaining of this pain. And apparently, the echo tech, the echocardiographic tech, picked up on ultrasound, or I guess, or through the echo, that she had this thing. And what happened? She was like 6 months pregnant. I think we operated on her, and
she had a special type of aortic problem. It's called an aortic dissection, where basically, and it's interesting that she was pregnant, and occasionally a pregnant woman will get hypertension. The blood pressure will go up, which is a known cause for an aortic dissection.
Wow.
John Ritter from Three's Company, if you remember, he had an aortic dissection. He actually died when he got to the hospital. It's a lethal disease, but sometimes you can get to the hospital quick enough to get operated on.
Right.
And usually the symptom is it feels like somebody's stabbing you in the back.
Wow.
Because literally the wall of the aorta splits down the middle.
Oh my gosh.
And it actually just runs all the way around. If you can get to the hospital alive and stable, there's a good chance you could survive the surgery. Right. And she was fortunate enough to get to the hospital.
Well, and if I remember correctly, we took her to the operating room, and then we had a team. We had the OB team come in, the obstetricians came in. They took the baby. It was only like 6 months. The baby survived, and the mom survived. I think everybody did really, really well.
Key is being at a hospital, and she was fortunate enough to be at a hospital that, like the medical center, that has all of these other specialties.
Wow.
Not just cardiac surgery, but as you mentioned, OB/GYN, so that specific care could be given to the the baby.
Wow, that's amazing. When we have patients in the hospital, we obviously want to prepare them for surgery. So you give them this booklet. You actually, it says going for heart surgery, what you need to know. Is this something you developed, or was this a team that did it? Or
it was not just me, but the team, and again the nursing staff who deal with the patients. Over the years, come up with a number of questions that the patients will ask.
Okay, so it's kind of like
time.
the frequently asked questions for open heart surgery, right?
Exactly. It's as frequently asked, but only in addition, they put it in pictorial form.
Okay.
So to add a little humor, they'll show you, for example, a picture of a heart, which is supposed to be the patient, and you'll see the patient's here smoking.
Right.
Smoking, as you know, is a risk factor. Just on the cover, you see the patient going to the hospital to get open heart surgery. And you see the suitcase with a little vein coming out, anticipating that the vein is going to be used for the surgery.
Right.
But it also gives you a lot of other, just simple, in pictorial form, easy to remember. And the biggest problem that patients will have is the apprehension prior to surgery, not knowing what to expect.
Sure.
And it explains.
And this kind of helps alleviate their fears and let them expect what's going to happen to them.
Yeah, exactly. And just to give you another example, one of the most frequently asked questions and problems and things that people remember after surgery are remembering what their loved one looked like after the surgery in the intensive care, because they're able to see the patient afterwards. So we have a picture in here, and it shows that there's a patient connected to all sorts of tubes, and it just looks like a disaster.
Yeah.
But if you know that beforehand, what to expect,
then
it certainly allays all their fears, and it's much better on the families of everyone.
So tell me, what's the course of, somebody comes in for open heart surgery, do they come in the day of surgery or the day before? How long do they stay? Well, what's their clinical course like? In
general, most of the patients that we see for open heart surgery are patients that have to stay in the hospital. They're diagnosed by the cardiologist, and they have to stay in the hospital because it'd be too risky to go home.
Okay.
But we do have about 25 to 30% of the patients will be seen electively. I'll see them in my office, and then we'll decide a week, 2 weeks from now, they'll come in the morning, and then we actually do the surgery that day. The hospital stay, the average length, and we're ranked second or third in the state.
Right.
For length of stay, which is between 4 and 5 days.
Wow. So after they have that complete surgery, they're out in 4 or 5 days?
That's correct.
Wow, that's terrific.
We do, this woman that I mentioned earlier, that we're going to do this minimally invasive aortic valve surgery on, the incision is going to be 7 centimeters. It's going to be the smallest incision. There are selected
and you'll do that
patients.
on the beating heart?
This is the one where she needs a valve, so it can't be done on a beating heart.
Okay.
But certainly we offer that as part of valve surgery.
Wow.
Many patients now are asking for it. The elective patients especially are candidates for this. If it's an emergency or an urgent case, you might not be a candidate for this smaller incision.
Right.
But certainly the elective patients are.
Now, so they have surgery today. Are they sitting up tomorrow? Are they? I mean, when do they start walking around and say, "Okay, I'm ready to go home"?
Yeah. Again, going back to the excellent nursing care, we get patients in the chair the next day, out of bed.
Really?
Off of the majority of the tubes are out.
Within 24 hours.
Within 24 hours,
That's
they're
great.
pretty much getting around.
Right.
The minimally invasive surgery, 2 or 3 days even, they're going home.
Wow. That's amazing.
Some patients opt to go to rehab, like a rehabilitation center for cardiac surgery. Most patients would rather go home. It's not necessary.
Not necessary to go to rehab. They can go directly to home.
That's correct. And
do they need home health or anything, or?
Some do. Not everyone does. Some of the patients who have orthopedic problems before surgery may want to have a home health aide come in once a day for a few weeks to get them along. Help them with their medication.
Right. And so we've got a specialized team of nurses for after surgery, and they know exactly how to take care of all the patients there. Try to get them out of bed as soon as they can, and they're usually home in 4 to 5 days, unless they're minimally invasive, and then it's less than that.
That's correct.
That's pretty amazing. Yeah. That's.
And like I said before, it's amazing. Like I said, 20 years ago, it was a lot. The average hospital stay was 10 days.
Wow.
So, and the average incision was 1.5 feet long. Now everything is much smaller.
Wow.
And the mortality rates in general for a coronary bypass the average patient has a risk of 1%, a 99% chance of everything going fine.
Wow, that's
Valve
great.
surgery, it's 97 to 99%.
Wow.
Everything going fine.
That's amazing.
So there's really no reason. I mean, it's riskier to do nothing. It's
Right.
riskier just to continue to treat with medicine.
Right.
So whenever you talk to patients, the key thing is try to allay that fear of the risk.
Right. Okay, so now I'm home after my 5 days stay in the hospital. Now what? What do I do? Can I run around the block? Can I, you know, what am I? What's my next?
Well, that's
steps?
a good question. In general, at the initial interview when I'm talking to patients, I'll say it takes a couple of months to get back to baseline and perfect. I don't like to sugarcoat it. It's a serious operation.
It's painful too, right? I mean,
it's painful,
yeah.
and you're not going to be playing golf in 2 or 3 months, for example. You're not going to drive a car for
Tyrone,
2 or 3 weeks.
If I have to have surgery, I got to get back to the golf course, man. You know,
well, then you're going to have a minimally invasive procedure,
well,
and then you can get back sooner.
All right, good. There you go.
But I think it's important that you try to give them an idea of what to expect.
Okay.
And if someone says that you'll be up and down within a few days, I think that's a little questionable.
Yeah. You know, one of the things we do at the medical center, we have the Heart Patient Support Network. It's something that we get patients who have had heart disease or any kind of procedure. They meet on Monday evenings. The next meeting is February 27th. Then they meet March 26th, April 23rd, and June 25th. We're going to show you some information about this on the TV. How important do you think it is for people to go to this kind of support group after having a major cardiac event?
I think it helps a lot because you deal with questions, the frequently asked questions. It feels that you're tied into a network and a support system, and it certainly helps. It helps in other areas. It helps a lot in cardiac surgery.
Right. And have you ever been to this support group? Have you ever seen any of the folks here?
Yes.
Yeah. And so we also try to bring the doctors in, and they give them a chance to answer questions. And some of the people that I actually went to the support group last week just to introduce myself, and the patients were very gratified. The thing they said they liked the best is, like, if I had open heart surgery and you had open heart surgery, we could talk about our experience, kind of what's happening 30 days afterwards. You know, if I had mine 2 months before and you were a month ahead of me, then you can kind of tell me kind of what the course of what to expect. And that seemed to help them a tremendous amount. I
mean, that helps. You can't put a price tag on that. That's great.
Yeah. It's really something. So as we were getting to wrap up, we really do have a comprehensive cardiac program at the medical center, and there's really no reason for anybody to go anywhere else. Any other comments about our surgery team? I know you're recruiting another doctor to...
We're recruiting, we're expanding our team, and we include all aspects of cardiac surgery, from minimally invasive to complex surgery. If you have a complex surgery, there's no need to go to New York or Philadelphia or anywhere else.
Right.
I've had 20 years experience with the other surgeon that's coming on. He has 20 years experience.
Wow, you're both 20 years. So remember we talked about it took you 17 years. So how old were you when you finally started going out on your own?
35.
See, he's only 36 now. So no, I'm kidding. Anyway, thank you all for coming. Dr. Krause, thank you so much. Our esteemed Chief of Cardiovascular Surgery. He does a great job at the Medical Center. If you have questions about anything that we've talked about today, please, you're welcome to come to our support group. On behalf of the Medical Center, thank you, and we'll see you next time.